Hi, my name is Michael Parker. I'm happy to spend some time with everyone on the topic of nasal congestion and sleep. Uh, we'll talk about the anatomy and physiology of the upper airway with respect to the dilemma of multitasking, right? So humans are unique. We have this nasal, oral, and hypopharyngeal airway. And when everything's working perfectly, we speak with it, we breathe with it, we take nutrition and liquids through it. And that's awesome, except for there are scenarios where that system is a little bit put upon. And occasionally there are moments of dysfunction, particularly with regard to airflow and sleep. And so let's talk about airflow, nasal patency, and things that contribute to airflow collapse, airflow obstruction. And specifically, we'll talk about nasal obstruction and the relationship nasal obstruction has on sleep, and talk about the continuum of obstruction and discuss risk factors for obstruction. So as physicians who care for the airway, we need to be mindful and be observant and know when to ask a few more questions and perhaps delve into the topic of nasal airflow and the relationship to sleep. So the function of the upper airway is put upon by the curse of multitasking, right? It's responsible for respiration, it's responsible for nutritional intake, and in humans, phonation, right? So we have to manage air, liquid, solids, and also produce communication via this upper airway. And that multitasking sometimes makes it challenging. Right, there are varied lumen requirements. Airflow changes depending upon my state of consciousness, my airflow while awake and my airflow while asleep. There's a change in my muscle tone between awake and asleep. And also changes in airflow and coordination of airflow during swallowing. So swallowing solids, swallowing liquids, I have to have neuromotor feedback and manage that. Otherwise, aspiration occurs and greater problems for the individual. And unique to humans is the notion of phonation, right? So here's this airway and lumen that carries liquids and solids, but also responsible for communication, producing sound and allowing us to speak and communicate with each other. Also unique to humans is this notion that that airway can get so relaxed that it obstructs, and snoring and obstructive sleep apnea occur. It does occur in a few other species, but humans seem to be pretty efficient at this notion of snoring and obstructive sleep apnea. So let's talk about some of that and see if we can't connect some dots. Right, so we'll start with the nose, right? The nose is that part of the lungs accessible to the index finger. But the nose plays a bigger role in that. It's really responsible for heat, humidification, and filtration of inspired air, right? So, and it does that with these very vascular turbinates that are under control of the autonomic nervous system, right? So here's this membrane that instantly senses the temperature and the humidity, is aware of our respiratory requirements and responds appropriately in a relatively efficient fashion. And there's some secondary nasal functions as well, the olfactory groove playing some role in our sense of smell, but really the primary nasal functions, those of heat, humidification, and filtration, seem to be under the watchful eye of our turbinates. And our turbinates are these vascular bumps inside our nose, which have control of under the autonomic nervous system. They have the ability to vasodilate and heat and humidify, or vasoconstrict and let improve airflow. It's this rich venous plexus that and its variability that seem to play the biggest role for variable nasal airflow issues and episodic congestion. There are some fixed skeletal anatomical pieces of the puzzle as well, right? I can have a deviated septum, I can have adenoidal hypertrophy, I can have nasal valve collapse, but the turbinates are a constant component of this story. The nasal valve and the nasal pharynx being the front end and the back end of our nasal airflow. So it's a complex setting and a lot of moving parts. And for most of us, most of the time, those parts seem to get along well and function reasonably well. But when nasal airflow becomes diminished and we have nasal obstruction, that can play a negative role with sleep. And nasal obstruction, specifically turbinate hypertrophy, contributes to snoring. It contributes to oral, pharyngeal, and hypopharyngeal obstruction, right? If I can't breathe through my nose, I have to open my mouth. And when I open my mouth, I change some anatomic relations that increase my risk for apneas and hypopneas in patients who might otherwise not have obstructive sleep apnea. So there's a number of moving parts and so let's roll up our sleeves and talk a little bit about that. Before we get going, a little bit on some definitions. In the sleep world, an apnea is defined as 10 seconds of no airflow with an associated drop in oxygen. A hypopnea is 10 seconds of diminished airflow with a 3% drop in oxygen. And we tend to focus mostly on the apneas and hypopneas per hour, the apnea-hypopnea index, with less than 5 events per hour being considered as normal, 5 to 15 events per hour is mild obstructive sleep apnea, and 15 to 30 events per hour is moderate, and more than 30 is severe. So am I just snoring? Am I having some apneas and hypopneas? And if I am, how frequent are those occurring? And that contributes to the severity of my disease. I don't always wake up when an apnea or hypopnea end, but I have certainly aroused myself out of restful sleep. So as the number of apneas and hypopneas increase, my perception of restfulness after sleep seems to diminish, right? And so who's at risk for these apneic and hypopneic events? What are things that we know are contributors to this? Well, certainly my BMI is a risk factor. As my BMI goes up, I have more obese, and my airway is not exempt from that airway crowding. As I age, my muscle tone diminishes and I'm less able to hold my airway open. With diminished muscle tone of sleep, we know that men are more likely to have obstructive sleep apnea than women, but when women become postmenopausal, they catch up. We know that family history plays a role, that members of family tend to share anatomical features. And so if I have a member of the family with obstructive sleep apnea, there's a high probability there's another member in the family. And again, there are a number of anatomical predisposing features: big tongue, small jaw, nasal obstruction, all increase my risk for developing obstructive sleep apnea. So this oral hypopharyngeal anatomy, we know that there's some bony contributors, right? On my mandible, my hyoid bone. We know that there's some cartilaginous structures, my epiglottis and my laryngeal cartilage. And we know that there's a host of soft tissue structures, my palatine, pharyngeal, and lingual tonsils, as well as the soft tissue and musculature that contribute to both phasic and tonic dilation of the airway. So all of these pieces have to play a role, and they have to cooperate in an efficient fashion to have no airflow obstruction, specifically when muscle tone is gone and I'm sleeping. So there's a lot of moving parts, and it makes it interesting and sometimes challenging. Right? So we have this notion of collapsing forces, right? So I have muscle tone holding my airway open while I'm awake. If I have increased force of inspiration, I have to work harder. I'm increasing my chance for hypoxia or for hypercapnia, increase CO2. And those two events can all by themselves increase my respiratory drive. I know that nasal obstruction can also contribute to collapsing forces. So can the supine position and anything that increases the extraluminal pressure, such as obesity or a genetic predisposition or some other anatomical problem. So there's a number of variables that come into play here. We kind of need to think about them all in our patients who present with nasal obstruction. Hey, gee, I can't breathe through my nose. I want to look at your airway and I want to pay attention and I want to ask these questions about sleeping and snoring and obstructing events. The challenge is we're sleeping when they happen. And so sometimes we're not aware of them. Sometimes our bed partner has to opine. But again, it's this notion of reduced activity of the upper airway dilators and loss of load compensation and reduction in pharyngeal caliper. So now I've got a narrower airway and I'm generating more negative inspiratory pressure and more airway resistance and more ability to collapse my airway, right? So this is this continuum of respiratory events, right? And I go from normal breathing with no obstruction, and as I relax, I start to vibrate my tissue. And if I obstruct my nose, I'm more likely to mouth breathe, which puts me at a higher risk for snoring and respiratory related arousal or upper airway resistance, right? And so as I increase the resistance, I'm increasing my ventilatory efforts and until the point where it wakes me up or it arouses me to the point where I restore muscle tone, but I've disrupted the quality of my sleep when I do that, right? And if it continues to progress, it can progress to a drop in my oxygen, and we call that a hypopnea if I'm continuing to breathe, or a complete airflow obstruction, which we call an apnea, which is defined as 10 seconds of nasal airflow, right? So it's this continuum we're on from primary snoring to airway resistance to obstructive events to obstructive sleep apnea. And nasal airflow plays a role, right? If I can keep my mouth closed and keep my nose patent, then I'm going to be in a more favorable position in my tongue, and I'm going to keep my airway more patent and be more likely to maintain breathing, more likely to not snore, more likely to not have obstructing events if I can keep my nasal airflow patent. Right? So how do we do that, right? I'm falling asleep. And this patency is determined by size and the balance between this collapsing, relaxing tissue and the dilating forces acting on the airway compliance, right? I want to try to hold my airway open. And again, retrognathia, big tonsils, tongue size, nasal obstruction, fatty deposits all play a role. And perhaps even the more we snore, the more vibration, the more edema, the more worse this process becomes as well, right? So there's a little bit of a positive feedback loop in this process. So it's complex, a lot of moving parts, but we know that nasal airflow plays a critical role in initiating this path, right? So this path from snoring, just vibrating the tissue of the pharynx, soft palate, and that turbulent airflow from this vibrating flaccid tissue. And again, the site of the vibration can vary. It can be the palate, it can be the tongue, it can be the hypopharynx. So there's a lot of moving parts, but if I can keep my mouth closed and keep my nose patent, I'm in a more favorable position to not let those events occur, right? There are some dilating efforts that we put forth when we're sleeping. I've got tensor palatini muscles and the genioglossus muscle trying to hold my airway open. This activity is reduced during sleep. There's some wakeful stimuli that try to hold our palate open. And so that increased tonic phase tends to help us while we're awake, and it helps compensate for the collapsibility of this tissue. And then the genioglossus muscle, our tongue, right? Again, as we fall asleep, that muscle relaxes, and that loss of wakefulness reduces both the responsiveness of both the tensor palatine and the genioglossus muscle, right? So we're set up to have this problem. We're protected from it to some degree because of positioning of our mandible with patent nasal airflow. And again, you lose that patent nasal airflow, and the genioglossus muscle and the tensor palatine muscles lose their effectiveness of management of the airway, right? So in normals, as I'm falling asleep, if my airway muscles are relaxing, I'm increasing my negative inspiratory effort, and that negative inspiratory effort is responded to by the genioglossus muscle. So I get a little more muscle tone just because I'm noticing the suck that my airway is creating, and my tongue tenses just a little bit. OSA patients perhaps don't show that same degree of muscle tension. And it might be that they're already maxed out, right? They're already obstructing. They're already got a tongue that's trying to hold the airway open. And as you relax it, it's probably already maxed out. It can't bring back any more muscle tone without waking you up, right? Which is often reported by our patients with obstructive sleep apnea, right? So this enhanced dilator activity in response to negative pressure seems to be the main activation of the genioglossus muscle. And again, our OSA patients have already increased tone when they're awake, so they don't have this reserve, if you will. They've already maxed out their respiratory drive. So what else contributes to it? So I've got this maxed out dilating musculature, and then I can make it worse with a big tongue. I can make it worse with extra fatty deposition in my hypopharynx. I can make it worse, more likely to obstruct with craniofacial abnormalities, a small mandible. And I can make it worse with nasal obstruction because now I more favorably position my tongue and my genioglossus to obstruct, right? So nasal patency plays a big role here, right? So what's our airway do when we fall asleep, right? The other thing that happens, right, most of the time when we're sleeping, we're lying down. And when we lie down, we redistribute some blood flow. So that redistribution of blood flow results in a little bit of turbinate congestion. And that turbinate congestion results in mouth breathing. And right, so if I can elevate my head of bed or reduce turbinate congestion, that may help me keep my nasal airflow patent, and that may lessen the risk of me sliding down this pathway of airway obstruction. And there's some pretty good work on positional turbinate contribution to airflow obstruction and nasal obstruction. There's also this notion that there's some diurnal turbinate variability, right? So we, as humans, have a cortisol circadian rhythm, right? And so our own steroid production seems to decline at night when we're sleeping, and that declination of cortisone seems to allow us to suppress less well our own inflammatory process, right? So if I have underlying allergic rhinitis and it's nighttime, I'm controlling that inflammation less well. So not only do I have a positional contribution to nasal obstruction, but I also have diminished steroid suppression of that nasal obstruction, and so I'm more likely to have some congestion, right? So that there is a circadian rhythm to our nasal airflow. Depending upon the timing of our nasal airflow obstruction, it can have an influence on facial growth, right? We've all seen children with adenoidal facies, allergic shiners, right? So here's this backup of venous pressure, the allergic shiners, or this complete obstruction in nasal airflow causing me to be a chronic mouth breather, and that results in some early facial growth changes. Is it possible to have those change, right? I can end up with sort of mid-face vertical maxillary excess. I end up with a narrow palate, high arch narrow palate, and sort of an elongated mid-face because I couldn't keep my mouth closed to have my tongue press out on my maxilla. And so this sort of crossbite that develops in vertical maxillary excess and relative hypognathia, which then results in less anterior projection of the tongue and contributes to more airflow obstruction. So mid-face development also plays a major role. And again, it can all kind of come back to nasal airflow, right? If I can't breathe through my nose, I'm mouth open. If I'm mouth open, I'm more likely to contribute to this lateral mid-face narrowing, and then ultimately a crossbite and dental malocclusion. So we need to pay attention to nasal obstruction in our 4-year-old population, and make sure there isn't some treatable cause of the nasal obstruction that's setting them up for mid-face developmental issues, right? So, and at some point, if we identify it, can we reverse it, right? So if I can change the patient from a mouth breather to a nose breather, if I can look at their adenoids or their turbinates and treat their allergies and treat their adenoidal hypertrophy and improve their nasal airflow, can I get their mid-face growth to change and get their mandible to come back into normal growth expectations? And the answer, yeah, there's some pretty good studies that support that. So we need to be mindful of nasal airflow in our younger patients, right? We also need to pay attention to our oral pharyngeal exam, right? And the crowded exam in a patient who's in our office for some other reason, this notion of the Mallampati score increasing the risk of airflow issues when the patient's asleep. And so they may be in our office for some other reason because of their asthma or their allergies, and a quick peek in the oral cavity, and now we're talking about airflow and sleeping and snoring, and it might prompt a whole new set of questions and concerns for us. So we need to pay attention to the whole upper airway, and not just the inflammatory conditions, but the anatomical conditions that may contribute to the inflammation, right? So a nice picture of some tonsil hypertrophy. And again, this notion of retrognathia developing because of loss of soft tissue support, and again, this narrow upper palate, dental malocclusion, and again, related to poor nasal airflow. And the answer is yeah, there's pretty good data supporting the notion that poor nasal airflow, chronic mouth breathing contributes to the formation of retrognathia and small mandibular development. We need to not forget about the lower airway, or at least the airway, the hypopharynx, epiglottis, vocal cords. In those patients with snoring and airway obstruction, we want to check their base of tongue, make sure the lingual tonsils, epiglottis, and vocal cords are abnormal. Every so often, we'll find an obstruction in the base of tongue, contributing to airflow obstruction. That obviously would worsen with diminished muscle tone at nighttime. But if we just look at nasal obstruction, so let's and there's several studies that follow this reasoning here. Let's take 10 healthy women and ask them to volunteer to spend a night in the sleep lab, right? So these are young women, average age 22, with an average BMI of 22. So they're thin, young women with no obstructive sleep apnea. And now bring them back for a second night in the sleep lab. And on their second night, the only difference is we're going to plug their nose. When we plug their nose, we have a dramatic impact on their apnea-hypopnea index. We go from an average of an apnea-hypopnea index of 2 to an apnea-hypopnea index of 33. So we go from no disease to severe disease in these thin young women, which are the sort of the lowest risk group for obstructive sleep apnea. Let's choose the people who don't have obstructive sleep apnea, bring them back, plug their nose, and we create severe obstructive sleep apnea just because we plug their nose. That's remarkable. And it kind of hints at, gee, well, what if we go the other way? What if we take people with nasal obstruction and unplug their nose? Will we have the same dramatic improvement in their airflow? And the answer is, well, sometimes, but not every time, because sometimes there are more variables contributing to their airflow obstruction. So do they have a high BMI? Do they have some airway redundancy in addition to their nasal obstruction? So we don't get everybody better when we improve their nasal airflow, but in some patients, nasal airflow is a key contributor to this problem, right? So some of the common causes of nasal obstruction and sinonasal edema, obviously anatomical abnormalities are at the top of the list. Do I have a deviated septum? Do I have turbinate hypertrophy? Am I having problems with chronic viral illnesses or upper respiratory infections? Is there allergic disease playing some role, and can we manage that? Is there some chronic irritant that they're exposed to at the work or home environment? Is there adenoidal hypertrophy, or is this just positional turbinate hypertrophy? And there's a little bit of data suggesting that even patients with gastroesophageal reflux disease can end up with nasal obstruction, right? So we need to kind of be mindful of this in our patients with nasal obstruction in both directions, right? If I have a sleep patient, I investigate their nasal airflow and contributors to nasal obstruction. And if I have patients with nasal airflow issues, I want to be asking the questions about their sleep quality and ruling out obstructive sleep apnea. Right? So mouth position, as we mentioned, has this effect on the critical closing pressure of the airway, right? So the more positive that pressure, the more I have to use muscle tone to hold my airway open. And if I close my mouth, I have a more negative P, a smaller P closing pressure, right? So it's harder to close your airway, to suck it closed if your mouth is closed. I can't generate enough pressure through my nose. So mouth breathing enhances our ability to suck our airway closed, right? So the fundamental feature, right, in pathogenesis of airway obstruction during sleep is our inability to keep our airway channel patent from the oral cavity through the nose, from the lungs, right? So if it was a rigid tube, this problem would be non-existent, but it isn't a rigid tube. It's a muscular tube with a few areas of rigid support. So we need to think about airway anatomy starting in the nose and making sure the nose is patent in our patients who are concerned about airway obstruction, right? So it's the anatomy, the size, shape of the upper airway, the airway wall compliance, the upper muscle activity, external contrinsic forces, lung volume, caudal traction, vascular filling, mucosal adhesions, all variables that come into play. So we need to think about all these things on a regular basis, right? And just to throw a few more cogs in the wheel here, we know that REM sleep seems to be more problematic for our patients with obstructive sleep apnea. And that's because we have diminished muscle tone. So our airway becomes more likely to obstruct in REM sleep, just to make it even more interesting. So to jump to treatment options just for a second or two, right? If I have obstructive sleep apnea, here's a patient with nasal airflow issues. We've talked to them. Yeah, maybe they do have some obstructive sleep apnea. We test them and confirm that they do. What are our options for managing that? And there are historically 5 treatment options: CPAP, which is continuous positive airway pressure; weight loss, which patients struggle with; mandibular advancement device, let me pull your chin forward, which will pull your tongue forward, which may hold your airway open. Let's work on some positional therapy. Some folks are just worsening on when they're supine, so let's keep them from laying supine. Or occasionally you'll have patients with surgical options. Again, at the top of the surgical option is, can I keep your nose open so I can keep your mouth closed? And maybe that enhances our abilities to control this. And there are some other risk factors for sleep disorder breathing, right? Smoking is obviously an airway irritant, and alcohol decreases muscle tone. And we know that apnea-hypopnea index, it worsens after alcohol consumption. So in our patients, we need to have that discussion. And there are also some associated conditions: hypothyroidism, acromegaly, amyloidosis, focal cord paralysis, Marfan's Down syndrome, neuromuscular disorders, all increase the risk for airway obstruction. So in our patients with obstructive sleep apnea who don't have nasal obstruction, we need to have sort of this additional list in our brain of other things to ask about, or at least rule out. So it's complex, right? Airway obstruction during sleep is not just a single event, but there's a lot of moving parts, right? There's contribution from bony anatomy. There's dynamic muscular activity that plays a role, and then intraluminal and extraluminal variables that all play some role, as well as the key piece of the puzzle, the nasal obstruction. And nasal obstruction can produce significant obstructive sleep apnea in otherwise normal individuals. And reversing the obstruction all by itself may not address all the variables. But we need to think about it. We need to think about sleep in our patients with nasal obstruction, and think about nasal obstruction in our patients who are seeing us for sleep apnea. So with that note, thank you very much. It's been a pleasure chatting with you. I hope you find this all useful, and at some point, hope to see you all in the future. Thanks again.